Good morning, it's me, Dr. Mohammad Kazafi, and good evening, we are there the evening, and you are watching Dr. Mohammad Kazafi Views. I want to bring a topic regarding the spinal metastasis. I want to talk about it, and I prepared a little this lecture for I think regarding the importance of this and how we deal, how we approach, in my humble opinion, according to the our current data. Actually, the 65-year-old female with the history of the chronic lumbar spondylosis and no significant trauma present with the mid-thoracic back pain for 10 weeks, refractory to the conservative measure and progressive difficulty with ambulation. Past medical history otherwise was unremarkable, and the tender to palpation at the mid-thoracic midline spine and normal upper extremity examination, right lower extremity 4 by 5 weakness at the iliopsoas and the quadriceps, sensory level at T7 with decreased pinprick and the normal rectal tone. Regarding the differential diagnosis, in my humble opinion, there is definitely you cannot go in immediately over the spinal metastasis, but definitely spinal metastasis and one of my topic because the age is high, so that's why and I will go with the differential diagnosis here, such as definitely spinal metastasis or the thoracic disc herniation or the osteoporotic compression fracture or the spinal cord tumor or the AVM more chronic AVM more chronic course when the stepwise progression, infection, spinal abscess, or we can say maybe the history of the intravenous device, or the manifestation of infection for other reasons in this elderly age of that lady, and MS and multiple sclerosis, transverse myelopathy, vitamin B12 deficiency, and such as alcoholism or the radiation myelopathy. So these are the differential diagnosis, but top of it, definitely 3-4 are top of it: thoracic disc herniation, osteoporotic compression fracture, and metastatic spinal injury, or metastatic spine or fractures due to the metastasis are still on my top of the list, because the complaint according to that lady, that 65-year-old, as I mentioned, is a chronic back pain, chronic lumbar spondylosis with no significant trauma, and then mid-thoracic back pain for last 10 weeks and refractory to the conservative measurement and progressive difficulty with the ambulation. These all are going in the favor of that. And sensory level is coming T7 with the decreased pinprick, so tumor or the metastasis cannot be denied, and the disc simultaneously cannot be denied until proven. So now, actually, I want to show this picture. Just it is not my patient's picture, but I just want to show for this, just for the I can say the lecture purpose. You can appreciate here there is a at the upper thoracic, at mid thoracic, and the lower thoracic, the 3 vertebrae involved, and these are because of the all because of the metastatic disease of the spine, especially in the thoracic spine. So this thoracic spine MRI shows there the sagittal and the axial image of the T7 enhancing lesion with the dural extension, involvement of the pedicle and the posterior element is suggestive for the metastatic process, and no serpingeous vascular suggestive for the AVM are seen. No other segment of the spine are involved, and the differential spinal metastasis with anterior cord compression less likely spinal epidural abscess. Further workup like the laboratory, we can see the routine lab, ESR, CRP, and imaging as I did for this patient, for my patient, such as the CT scan, chest, abdomen, and the pelvis, and the mammogram definitely for that lady, evaluation for the systemic burden, or the CT for the evaluation of the bony quality, and or we can say the precise location. Definitely CT scan is helpful, but definitely we are going for the MRI, magnetic resonance imaging, to see the soft tissue and the involvement of or an encroachment of the canal. Definitely we can see on the CT scan as well, but the MRI give us some more information. As a surgeon, as a neurosurgeon, if you are a spinal surgeon, definitely you are looking for it, and you are very eager to see this. So the pathophysiology, actually, the 90% of the spinal tumors are metastatic in origin, and the patient has the metastatic involvement of the mid-thoracic spine in the setting of the malignancy. Circulating tumor cells can lead to the localization of the different organs, and the bone marrow of the mid-thoracic spine receive abundant blood flow and provides a concurrent rich microenvironment for the metastatic cell. With time, the micrometastases lead to the erosion of the bone and the pathological fracture with potential of the epidural extension, and with recent improvement in molecular therapies, the prognosis for patient is the heterogeneous, with some surviving multiple years in the setting at stage 4 cancer. 90% of the spinal tumors are metastatic in origin, and the patients are the metastatic involvement of the mid-thoracic spine is much more, and it is the setting of the malignancy occurring tumor cells, and can lead to the colonization of the different organ, and the bone marrow of the mid-thoracic spine receive abundant blood flow and provide a nutrient-rich microenvironment for the metastatic cell. With time, the micrometastases lead to the erosion of the bone and pathological fracture, with the potential of epidural extension, with recent improvement in the molecular therapies for prognosis for patient in heterogeneous, and with some surviving multiple years in the setting of the stage 4 cancer. The treatment option, definitely we have here the medical, which is called the corticosteroid, are indicated for the cord compression, biopsy in the very rare performed in the setting of active cancer, and the radiation. Radiation can provide pain palliation, and the time reduce the epidural component. However, these benefits require time and do not address pathological fracture that are often present. Renal cancer, melanoma, triple negative breast cancer, and NSCLSC are relatively radioresistant. Prospective randomized trial indicate that the circumferential decompression for the cord compression or the superior to the radiation alone. Thus, in the setting of the symptomatic cord compression, radiation by itself is typical reserved for the poor surgical candidate or extremely radiosensitive lesion. So you can understand that the definitely medical corticosteroid to decrease the edema and the cord compression, and then simultaneously we are going for the biopsy to confirm the type of the cancer or the what kind of the cancer and where it came. It is really performed actually, but sometime it needed, so we can go. And the radiation, you know that the radiation can provide the pain palliation and the time reduce the aqueduct epidural component. However, these benefits require time and do not address the pathological fractures that are often persistent. So the rectal cancer, melanoma, triple negative breast cancer, and NSCLS are negatively radio resistant. And prospective randomized trial indicate that the circumferential decompression of the cord compression is superior to the radiation alone, and this is the setting for the symptomatic cord compression, and the radiation by itself is typically reserved for the poor surgical candidate or extremely radiosensitive lesions. Interventional, you know that the intervention vertebroplasty with the posterior vertebral wall disruption contraindicated, and it is the balloon expansion with kyphoplasty, and also is not very encouraging, but people are doing. They have the mastery in this. They can do that. But these modalities can be effective with metastasis that results in compression fracture, and the vertebroplasty can also be augmented with the ablation. Preoperative ablation of hypervascular tumor can dramatically reduce blood loss. And here surgical we can do the laminectomy. Thoracic laminectomy may provide some benefit by removing the posterior element, but prospective studies have shown poor outcome in the setting of the anterior cord compression, and the separation surgery such as the wedge laminectomies plus minus instrumentation with the removal of the tumor and the immediately adjacent to the cord followed by the radiotherapy often is appealing when the vertebral body are mostly intact. Transthoracic corpectomy, anterior corpectomy with mini thoracotomy usually supplement and the posterior decompression and instrumentation. This is the standard approach, and the posterior corpectomy and the fusion, circumferential compression or the reconstruction was a lateral extracavitary approach has become less challenging due to the advancement in the instrumentation. In general, corpectomies provide significant benefit when there are the severe fracture of the deformity. So posterior corpectomy and the fusion or circumferential decompression and the reconstruction was definitely a lateral excavatory approach has become less challenging due to the advancement in the instrumentation. But in general, correction and corpectomies provide the significant benefit when there are the severe fracture or deformity, and we have now a very good tool to cover that corpectomy defects, and we can fill with that, or we have and we have the gadget that we can improve that the patient can improve after the surgery, and definitely it is considered superior for as compared to the radiotherapy, even though because you are decreasing the tumorous cell load significantly or very efficiently. And there is a transthoracic corpectomy is also an option, and this anterior corpectomy with the minimal thoracotomy or the mini thoracotomy usually supplemented with the posterior decompression and instrumentation. This is the we can say the standard approach, and it is very popular initial days, and I did multiple time in Pakistan in Liaquat National Hospital when I was working there for my seniors, even though definitely this is very easy. And the laminectomy, there the thoracic laminectomy may provide some benefit for removing the posterior element, but prospective study have shown the poor outcome in setting of the anterior cord compression. So the separation surgery such as the wedge laminectomy plus minus instrumentation with the removal of the tumor immediately adjacent to the cord followed by the radiotherapy or stereotactic radiosurgery is appealing when the vertebral body is mostly intact. Surgical technique I want to mention here, like that you can say there is a posterior modified lateral extracavitary approach and in a prone position, and neuromonitoring and the fluoroscope for making incision are performed, and the bilateral transfer process 2 level above and below tumor and segment were dissected for the costotransversectomy, and the rib had at the tumor segment, and the head 1 level below should be exposed on the right, and the laminectomies are performed at the level of the vertebrectomy, and at the level above, the superior and the inferior facet of the vertebrectomy level are drilled away, and the inferior facet of the level above and the superior facet of the level below are also removed without damaging the attached pedicle. Because it is not very difficult, but I want to mention in the posterior modified lateral extracavitary approach, prone positioning and the neuromonitoring, then fluoroscopy for making incision are performed, and bilateral transfer process 2 level above and below tumor segment are dissected. So for costotransversectomy, the rib head at the tumor segment and the rib head 1 level below should be exposed on the right side. So the laminectomies are performed at the level of the vertebrectomy and at the level and at the level above. So the superior and inferior facet of the vertebrectomy level are drilled away, and the inferior facet of the level above and the superior facet of the level below are also removed without damaging the attached pedicle. By removing these structures, the relevant disc space, pedicle, and the nerve root are fully exposed, and in the thoracic spine, and the nerve root can be, we can say this is the because when you are performing the laminectomies and at the level of vertebrectomy and at the level above and the superior and inferior facet of the vertebrectomy level and drilled away, and the inferior facet of the level above and the superior aspect of the level below are also removed without damaging the attached pedicle. And by removing these structures, the relevant disc space and the pedicles and the nerve root are fully exposed. So the thoracic spine, the nerve root can be tied off if needed. So for the costotransversectomy, approximately, for example, 2 centimeter of the rib distal to the transfer process of the level of the vertebrectomy and rib at the level below or exposed, and the transfer process at this level are often removed, and approximately 1.5 centimeter distal to the lateral tip of the resected transfer process, a plane is developed between the pleural and the rib, and the proximal rib should then be removed in the piecemeal fusion. Of note, a Cobb elevator is often useful to dissect the tissue away from the rib head and lateral vertebral body. The removal of the rib head exposes the lateral aspect of the disc space above and the below. Here I want to mention one thing. These pictures I show in front of you in C, A, B, or C and the D. When you see A, there is you can appreciate there's a laminectomy done appropriately, and you remove the facet above and facet below, just securing pedicle sparing surgery, and in that you can appreciate the thoracic nerves, and you can appreciate the spinal cord by itself, and you can appreciate here in the B there is, you can go through this from posterior side, the drill is going inside, and once you achieve from one side, and you remove the damaged or metastatic lesion of the body, and then again you are putting there, and it is safer in that regard. You don't have to encounter from the front, and no need to go from front, although from front it is not very difficult, and but you can achieve somehow the 360 approach and circumferential removal of the hair in the picture C and the picture D. You can appreciate how the cage has been placed, and you have to sacrifice the attachment of a rib here, and then you can one nerve, thoracic nerve, you can sacrifice there for the bigger cause, and definitely it is the one nerve morbidity, or the one nerve deliberately neurectomy, and then you are putting the cage. This is the procedure I just want to show you. I don't want to make you should agree with me and you want to go from the anterior or from the posterolateral extracavitary, but this is the posterolateral extracavitary, and you can approach in that position also. Actually, this midline incision with the laminectomy and vasectomy expose the spinal cord from the pedicle screw above to the pedicle below of the affected level, and then, as you saw in that picture, the removal of the pedicle and use of the transpedicular corridor to perform the corpectomy and the removal of the disc above and the below. And after tying of the thoracic root, and delivery of the expandable cage there, and the expansion of the cage to expand to the inferior end plate of the vertebral segment above and superior end plate and the vertebral segment below. So the pedicle are then removed bilaterally, and a vertebrectomy or corpectomy is performed using the extracavitary approach on the right. And the transpedicular approach is employed in the contralateral side, which allow complete vertebral segment removal, and the placement of the expandable cage should then be straightforward. An angle holder for the cage is extremely helpful to place the cage in the midline, and the posterior fixation 2 to 3 level above and below is then employed. Here, there is if we can say, there is the pedicle are removed and then bilaterally, and the vertebrectomy or the corpectomy as performed and using the extracavitary approach on the right. And this transpedicular approach is employed in the contralateral side, which allow complete vertebral segment removal. And the placement of the expandable cage should then be straightforward on the angle holder for the cage, and is extremely helpful to place the cage in the midline, and the posterior fixed level above and below is then employed. Here I mentioned a lot of things for you, but for the transthoracic corpectomy, during this approach, it is key to position the patient in the lateral with fluoroscopy at the beginning of the case, and during the resection of the vertebral segment, care should be taken to identify the pedicle and foramen to avoid incidental durotomy, and preoperative embolization when available can help reduce blood loss, particularly in the case of the renal cell cancer. Posterior corpectomy and fusion. During this approach, it is preferable to perform costotransversectomy or the transpedicular decompression on the right to avoid inevident aortic injury, and prior to the resection of the vertebral body, vertical control and alignment should be maintained with temporary rod fixation. If insertion of the titanium cage is difficult, then the polymethylene methyl acrylate and with pins can be used, and this polyethylene and a peak cages allow for the better visualization of neural element on follow-up MRI, and this meticulous multi-layer closure is required as there is a high incidence of the wound healing complications. So there is some benefit of this titanium cage, but definitely you should know that peak cage can be used and it is helpful, and during approach when we are approaching posterior corpectomy and fusion, then during this it is preferable to perform the costotransversectomy or the transpedicular decompression on the right to avoid inadvertent aortic injury, and prior to the resection of the vertebral body, vertical control and alignment should be maintained with the temporary rod fixation. And if insertion of the titanium cage is difficult, then we have the option of the methyl and a methacrylate, which is called the PMMA, with pin can be used, or poly and ether ketone peak cages allow for further visualization of the neural element. So these are the options we have, and we can use this. As a neurosurgeon, people knows that how we can use that. It's not extraordinarily difficult to do and understand. And during this approach, when we are going the transthoracic, which I like much because I was prone to do this, and I did multiple times in Pakistan in Liaquat National Hospital for my seniors, even though when I was junior. So during this approach, it is key to position in the patient and true lateral with fluoroscopy at the beginning of the case. And during the resection of the vertebral segment, care should be taken to identify the pedicle and foramen to avoid the incidental durotomy, because a durotomy can happen here, but a good surgeon who have a very good 3D mind, they can 3D mind, definitely very mandatory for surgery, and especially in the spinal surgery, and the pre-operative embolization, and when available, can help reduce the blood loss, particularly in the case of the renal cell cancer. I would like to tell you one more thing here, and then we conclude. Because I am going towards this topic, some literature, and before I try to present like a case for the analogy, but now I want to show this picture deliberately to you. You can appreciate there the vertebral body, and then you can see in the pink shaded metastasis in the axial and the sagittal views, and how it affecting to the canal and affecting the vertebral body. And the involvement, and you should understand the involvement. You can see the epidural space, what happened with this tumor and what happened over the spinal cord here. So as you know, there is definitely the spinal metastases are the most common tumor of the spine, and it is very mandatory to know everybody that as a spinal surgeon, that comprising 90% of the mass encountered with spinal imaging, and the spinal metastases are more commonly found as a bone metastasis, although they are not limited to the bone metastasis and approximately 20% with the symptom of the spinal canal invasion and the cord compression with the spinal canal or the spinal column. And metastasis is more commonly found in the thoracic region and followed by then lumbar region, and while then the cervical region is the least likely place we found. While evaluating the spinal metastasis on MRI imaging, a defining feature of these lesions is the sparing of the intervertebral disc space, and this disc space is always involved during infection. As our elders were telling, that if you are looking there's something abnormal in the disc, you consider the infection, and if anything you are abnormal considering in the pedicle or in the body, then you can consider there the neoplastic lesion or maybe the metastatic lesion. So here that is very important to understand that a metastatic disease to the spine is spread through the several different routes, which include the venous hematogenous spread versus the arterial spread and the direct tumor extension, and lastly lymphatic spread. Although the route mentioned above and the hematogenous spread through the Batson plexus symptoms is the most common pathway for tumor embolization and spinal invasion. The following summary emphasizes the essential knowledge necessary to have while treating patients with the spinal metastasis. The most common primary malignancy predominantly metastasized to the spine include and following tumors in the descending order, and the breast is 21%, lung is 19%, prostate is 7.5%, kidney is 5%, gastrointestinal tract is 5%, thyroid is 3%. While all tumor can seed to the spinal cord, but most the breast, lung, and the prostate. So when you see these three things, definitely or exclude these three things, definitely 50% you have excluded, and simultaneously in female you excluded 50%, because in female there is the breast is high more than 21 to 25%, and the lungs definitely it's the same, almost 18%. So it is roughly 50%. With 2 or 3 organs you can exclude, and the further by the kidney, adding the kidney, the GI, and the thyroid as well. While the exact mechanism and the gene expression necessary for the tumor invasion of the spine is a focus of the continuous active research, and the presence of the certain factor like the RANK and RANKI, this is called the receptor activator of the nuclear factor kappa beta, which is called the NFKB legend, and which interact with the receptor to activate osteoclast cell, appear to play a central role in setting as an island for the invasion. So this is a consideration that not osteoblastic activity, the osteoclastic activity, and this receptor activate the osteoclast cells, and these specifically the nuclear factor and a kappa beta. And spinal metastasis is a common condition encountered by the practitioner while treating oncological patient in a study of the post-mortem cadaver. The examination of the cancer patient with the known the prevalence of the spinal metastasis was as high as 70 to 90% for breast and the prostate as the primary type of cancer, and morbidity related to the spinal metastasis is related to the excruciating back pain requiring high dose of the necrotic medication for the management. Pathological bone fracture, hypercalcemia, and the spinal cord compression due to the invasion of the epidural space. So the rare spinal metastasis will seed inside the spinal cord itself with no apparent bone involvement, and in these cases, when there is no known history of the primary cancer, the diagnosis of the metastatic lesion becomes difficult, and often the correct diagnosis is determined after pathology confirms the type of the tumor. So metastatic spinal metastasis is a common condition, and you know that the 70 to 90% of the breast and the prostate are the primary type of the cancer, and the morbidity related to the spinal metastasis is related to the excruciating back pain and required the high dose of the narcotic medication for the management, and pathological bone fracture also, hypercalcemia, spinal cord compression due to the invasion of the epidural space also there. So the general spread of the metastatic involve hematogenous spread to the center of the vertebral body, although an initial interaction between tumor-associated factor and intrinsic bone cell like osteoclasts, a nidus of invasion, is established. More commonly, the tumor spread backward when involving the pedicle, which is an important part. Yes, it is a very important part and to understand here, and we can appreciate like that, because though the initial interaction between the tumor associated factor and intrinsic bone cell like osteoclast, nidus of the invasion, is definitely established, and more commonly the tumor is spread backward often involve pedicle, and which is an important part or important point of the understanding for surgical management of the spinal metastasis that would require the spinal stabilization. Due to this fact, the screw fixation through the involved pedicle often is the non-optimal and required extending fusion of the several segments above and below the lesion, and commonly the blood supply to the metastatic nidus come from the particular arteries, making selective embolization through interventional procedure a viable option. And the further understanding of the interaction between invading metastasis and surrounding bone cell and factor produced like interleukin 6 and interleukin 1 and transforming growth factor and beta and the rank RANK, as I mentioned below, or you can say RANK. I have offered the chemical therapy in the treatment of the painful bone metastasis, and so especially the breast and the prostate, as known premiers, a complete description of the mechanism and the factor involved is outside the scope of the short clinical focus review. And the pain is the most common presenting complaint in patients with the spinal metastasis. A high clinical suspicion should be present in any oncological patient and the patient with the neck or the back pain. While the pain is not the most freesome or the morbid symptom of the spinal metastasis, it is the most common initial symptom required evaluation for the treating physician. In addition to being initial presenting symptom, neck and the back pain in metastasis is quite often localized, requiring further diagnostic imaging on the patient that cannot undergo complete imaging of the spine. And the pain is aching and deep and often occur at the night and wake the patient from the sleep. And also if nerve involvement has occurred, and which would suggest a great extension of the tumor, and the pain is sharp and shooting in the specific dermatomal distribution. When the tumor has extended inside the spinal canal, and motor and the sensory weakness may become permanent and more worrisome. And the defining concept for the treatment of the spinal metastasis include the degree of the weakness and the extension of the deficit. The more severe the deficit is often presentation, the worse the chance for the recovery. It is very important words I want to mention here. The more severe the deficit is upon presentation, the worse the chance are for recovery, and all time lapse from the deficit progression to the physician identifying causing determine the possibility and the chance for the recovery. The simplest test of often available for evaluate the oncological patient present with the neck or the back pain is the X-ray of the spinal column. Plain anterior and posterior and the lateral images are often non-sensitive or the specific and require at least 50% of the bone erosion before an abnormality can be observed. And the spine magnetic resonance imaging is the gold standard for evaluating this lesion. An MRI would show extension level involved in the canal compromises as well as provide clue to the etiology for the metastasis. However, this is not always possible. For example, when a patient has an implanted pacemaker in the internal defibrillator, so the myelography associated with or without computerized tomography imaging should be considered in patients that are not candidate for MRI, but the myelography provides the advantage of the sending cerebrospinal fluid for pathology evaluation, but it has significant limitation when the lesion completely occludes the canal, and in this case the multiple spinal injection of contrast might be required to bypass the level of the obstruction. And the positron emission tomography scan is another modality that is sensitive but offer poor anatomical localization. Here I want to mention regarding the treatment, which I already discussed about the treatment in detail, but I want to mention here regarding the treatment somehow detail. But before that, I want to say the prognosis. The prognosis of the spinal metastasis is based on the multiple factor, including the general condition of the patient, primary malignancy, presence of the other visceral or skeletal or spinal metastasis, and neurological status. And the differential diagnosis primary spinal tumor include the myeloma, plasmacytoma, lymphoma, sarcoma, or spinal infection, which is pyogenic or granulomatous, such as the tuberculosis, cannot be excluded, and it is very important to be included. Regarding the treatment, I want to mention here, if metastasis involve multiple bone structure with no canal compromise or associated bone fracture, these patients can be managed without surgery. However, it is important to involve the spinal surgical oncologist in order to get advice regarding the spinal instability related to the multiple metastasis to the spine. However, most patients with the multiple spinal metastasis and the normal neurological exam may benefit primarily from the radiation therapy and chemotherapy, and if tissue for the pathological diagnosis is necessary, there is no primary or easy reachable metastasis with any other route, and the patient could benefit from the image guided biopsy of the bone lesion. And open biopsy is a rare or very rare necessary after the several attempt obtain a sample through the needle biopsy. When the tumor involves the spinal canal, then the treatment strategy change significantly, and the surgical consultation must be immediate, as the patient can progress to become the bed bound within days. And the studies have shown that the paralysis due to the metastatic spine disease significantly shorten the life expectancy of the cancer patient. On the other hand, surgical intervention of the patient with acute paralysis due to the spinal cord compression from the metastatic disease will significantly reduce mortality and the morbidity associated with the acute paralysis. Depending upon the rapidity and the seriousness of the neurological compromise, treatment of these patients may involve the addition of the steroid. Dexamethasone have been shown in clinical trial to decrease pain and improve symptoms. However, the exact dose that would benefit the patient the most is not known. And in one study comparing the bolus dose of the 100 milligram dexamethasone with 10 milligrams of dexamethasone bolus initial injection, no significant clinical benefit was observed with the higher dose. A good starting dose would be a bolus dose of the 10 milligram IV fluid, IV followed by the maintenance dose of the 10 milligram every 6 hourly, and the tapered over 2 weeks as the clinical scenario allows. Immediate imaging should be obtained to alleviate the extension and the possible surgical intervention. If the suspicion is low for a very radiosensitive tumor, if there is a complete paralysis there has present for more than 24-hour or the expected survival of the patient is less than 3 or 4 months, then the surgical intervention is warranted, and the further treatment after surgery should involve the multidisciplinary approach of the chemotherapy and focused radiation. Radiation therapy usually involves 30 gyron to 40 gyron in a 10 and a treatment assessment, and wound closure become a concern post radiation and chemotherapy, and the patient should be followed closely to identify wound breakdown and the repair promptly. The current algorithm for the treatment of the spinal metastasis is based on the NOMS, or which is called the neurological, oncological, mechanical, systemic framework, and this neurological, oncological, mechanical system framework and component include the evaluation of the grade of the epidural spinal cord compression, which is called the ESCC, epidural spinal cord compression, on MRI, and the neurological status of the patient preserved for the myelopathy, and the oncological component describe the radiosensitivity of the spinal tumor. Mechanical component involve the mechanical stability of the spinal column as evaluated by the spinal instability and the neoplastic score. And the systemic component describe the general systemic condition of the patient, that is the ability to tolerate surgery, and based on these parameters, the broad treatment category of these patients include the conventional external beam radiation therapy alone or with stabilization, and the spinal stereotactic radiotherapy alone or with stabilization, or a hybrid approach following separation surgery or decompression or surgical stabilization. So these are the things, but the complication must be important then to understand here, such as the pathological fracture and collapse, spinal cord or the other neural element injury, bleeding, persistent to treatment, tumor recurrence, infection secondary to the immunosuppressed state. So an infection secondary to the immunosuppressed state, tumor recurrence, resistance to the treatment, bleeding, spinal cord or other neural element injury, pathological fracture and collapse. Here all this, but the deterrence for the patient education, the patient should be aware. Patient should be aware of the possibility of the pathological collapse of the involved vertebra, and therefore bracing and external immobilization may sometime to recommend after from the surgical stabilization procedure by the treating clinician, and strict compliance with the physician recommendation is very important in such scenario. The prognosis for the neurological recovery depend upon the duration and the severity of the deficit, and therefore in situation of the compromised neurological status, the importance of the early consultation with a specialist spine surgeon cannot be understood. Patients with the spinal metastasis are best managed with the interprofessional team, and they include on the oncologist, radiation consultant, radiologist, pathologist, pain specialist, neuro-orthopedic surgeon, and palliative care nurse. Most of these patients have shortened life expectancy, and aggressive procedures are usually not warranted. Both pain service and palliative care should be involved early in the care, and key to ensure that the patient has a good quality of the life. Here I just want to explain a little bit about the spinal metastasis. I hope you like it. If you like it, please subscribe and share with us, share with the other people, and support us. Thank you so much, and thank you for supporting. Thank you so much. See you with one more good lecture.